Alexandria, from Alexandria facility, and she was a pretty good stick, but I was showing her how to do our methods at the hospital. I left it open for that tech to be able to just go in and do her whole spiel. Hi, my name is. I'm gonna draw blood and be positive. Well, she wasn't positive. She wasn't reassuring, and the patient looked at me and said, "Bobby, are you gonna draw or are you gonna let her draw?" No, I'm gonna let her do it. And looked up at me and said, "No, no, she looks new." I had to draw the patient. I walked out of that patient's room with a knot in my throat. Come to find out the patient had cancer. This was a classmate of mine. So, again, you never know what you're walking into. I've stuck babies. The first time I was training to learn how to stick a baby. So I was doing my clinicals. Funny story, walking into the nursery, we scrubbed up, put our gowns on, did everything we needed to do, walked in, and I always saw was the dad standing by the baby, looking into the nursery bed, and all he could do was do just like this, shaking his head. Person who was with me, showing me how to stick babies properly, started speaking and asking, "Hey, what's wrong with the baby? You know, what do we need to do? Um, how old is this baby?" Y'all, the baby looked the like he was 5 months old. The baby was 10 pounds and in respiratory distress. Just born. Baby was 5 hours old. Yeah, I see you over here. Yeah. um, I would be standing at the bed shaking my head no too. Yeah, 10-pound baby. He looked like a little turkey. Needless to say, on a positive note, the baby's healthy, um, and was able to go home within the next couple of days. You just never know what you see. Yes, I started on the floor. When I started on the floor, my areas of responsibility expanded real quick. I was only doing like one or two floors, like third floor, second floor. It just depends on what's going on. My responsibilities expanded. Within Miss Tina, what was it, about 6 months? I think I had told you at one time. I had gone from just doing one or two floors to doing ICU, short stay, same day surgery, recovery, ICU, and PCU. That's 6 different departments, folks. ICU is nothing to play with. Um, Most of your patients in ICU are very critical and on the verge of death. I hate to say it like that. They're and that's what ICU is. That's what PCU is. They're on the verge of death. Some have a central line in their necks. They do most of the time. The nurses will draw out of that line for you. Most of your other patients have veins as small as a thread. They're very small. They're very hard to get. So it just depends what's going on. I then went from that time, a position opened up at the South Campus for me to go into the ER. ER is another world. It's different than being on the floor. Um, ER, you see a lot of shooting, a lot of knife stabbings, heart attacks, strokes. You never know when it's going to happen. We had a patient um, 2 days ago, 3 days ago, excuse me. He was kind of, I won't say he was belligerent, but he was just not all there and kept pulling his IV out. Came time for a test to be drawn. I walked into the room. The nurse was in there. She said, such and such, I have to draw. I'm going to have to put another IV because you keep pulling your IV out. I'm going to put another IV. He kind of pushed her a little bit just to kind of like get her out of his way. And she wasn't. And he rolled over on his side. So she asked for me to get the charge nurse. I went to the door looking for the charge nurse. Didn't want to leave her in case he did get wild. Um, so another nurse stepped up. She was like, "What's wrong?" Nurse to nurse was talking, and they were saying, "Well, I don't want to deal with him because he's, being a little belligerent about things. I need help. We need a restraining." If you put restraints on a patient, you have to get doctor's orders. You can't just do it just because you want. So it was going to be a process, and we needed to get the IV flowing again. And when the second nurse walked up to the patient, such and such, we got to roll you over. We got to get on your back so we can give you another IV, and we need to draw some blood from you. It does sound like a lot of time had passed, but literally all this happened within about a minute and a half. And by the time we got back to him and saying, "Hey, you got to roll over," we were already in code blue. We started doing CPR. We worked on him for 40 minutes and never could get him back. You just never know what's going on. You never know what happens, how quick it can happen. I have gone from working nights on ER. I am now working at main campus again in ER. And I work from 6 in the morning till 6 in the night. I work 5 days on, 5 days off. I work 2 days on, 2 days off. Depending on your time schedule, depends on what kind of money you make. Of course, when you work in the evening and you work night and then you work graveyard, you make a little bit more money. It's what they call a diff pay. Right now in the ER, it's very hard. It's very stressful. In our hospital, the last report I got, which was day before yesterday, we have, I think it was 15 COVID positive patients. 2 are on vent. It's not a bad ratio. However, we now, COVID's kicking up so much that we have to convert one of our hospital floors to nothing but COVID patients. Effective last night, matter of fact, that was done. So now what that means is every time anybody goes on the floor to that particular level, I think it's going to be on 5th floor, they now have to wear a whole PPE. Bouffant N95s in the hospital, they're recommending for us not only to wear an N95, but we have to wear surgical masks as well over that. Of course, our PPE gown, what y'all have on in the classroom right now, that's breathable. Try wearing those, and I know everybody has seen it on the news, those blue PPEs. Ladies and gentlemen, that right there is like a plastic vinyl. I know that sounds like a weird combination, but those things make you hot quick. As soon as you go into a patient's room, you're sweating. That PPE is sticking to your skin just because of the sweat. You come out the room. Well, before you come out the room, you have to degown, get ready to go to your next patient's room. Redo the whole process. You got to wear shoe coverings. And if you don't wear a face shield, you have to wear goggles. The purpose of all of that is to make sure that you um, don't touch your face that much or at all. It's very stressful, especially in the ER. You go to one room. As soon as you come out, you got to get dressed again to get ready to go in another COVID patient's room. Every patient that is COVID positive or possible COVID positive, you have to wear the complete PPE. Okay, wear it 1 or 2 times. It's not so bad. When you're changing 15 times minimum, say in about 2 hours' time, that's a lot. I've had patients ask me in the ER, why? How do you like playing with people's blood? That's a funny one. Um, are you scared of this COVID? You can't be. In our minds, in the back of our minds, we can say, yeah, we are, because we go home. And if you have family, take the extra precaution. When you come into your door, if you can, strip right there, go take a shower, then hug on your family. If you're in the hospital, you can't be scared. You go in, you do your job. Our job, without us as phlebotomists, the job can't be done. We're the first. We got to get that blood into the lab so the doctors can see what's going on, so they can make the right medical decision to help this patient breathe better, to slow that heart down from a tachy to a regular sinus heart rhythm. Um, I've seen patients that are struggling to breathe because they've got so much fluid on their heart and lungs. We got to push medication to get them to start urinating or get that fluid off their body somehow. Um, and it's hard to see these patients struggle like that, especially when they're COVID positive and they're struggling to hear us talk because we've got all these masks and goggles or face shield covering our faces. It's hard. It's hard to watch these families lose a loved one because of COVID. Folks, that's what we signed up for. We signed up for anything that comes our way to be able to help this person, to help patients live a full life. I have been certified in CPR for 2 or 3 years now. We had a patient just come in the ER not long after COVID started or was confirmed, and patient coded on us that quick. He went to breathing, was breathing real good, and then his breathing started building up faster and harder. He ended up coding. We worked on him about an hour. I'll never forget this. He was my first person that I didn't have to, but I was part of the team to do CPR. And trust me, if you're doing it wrong, you can see on the monitors that you're not pressing hard enough. You're not going fast enough. Um, But at the end, whether the patient lives or not, everybody as a team knows that we did everything that we could to help that patient. Is it hard to lose one? Yes. Um, the youngest I've seen so far that we've not been able to survive or revive was an 11-day-old baby. That was hard. But then you got people that come in having heart attacks and um, their blood pressure's narrowing, and we end up getting blood work, getting it to the lab, getting the EKGs going, putting them on monitors, giving the medication, and a couple of days later, they're walking through the ER saying thank you. It was a survival thing that we got, you know. Makes us feel good that we are doing what we are doing. But like I said, it's hard at times, but our job is rewarding all the time to me. Miss Tina has taught me very well. I use her knowledge every day still. Whenever I'm doing an EKG, whenever I'm doing blood work, making sure it's like I can hear Miss Tina's voice saying, okay, make sure you anchor that vein down right. Don't touch that site after you clear it, after you wipe it with alcohol. Just make sure you get your EKG, your electrodes, they on the limbs, make sure they're turned up, not turned down. It's funny. She has said it so much in class that I still that I take it with me and still hear her voice. There's things that I've done in at work, on the job. I've seen some of these nurses, you know, Miss Tina's taught us on a limb, you take that electrode and you turn it up. They all face up. On the body, they face down. 9 times out of 10, they put all the electrodes down. You know how much drives me crazy? Miss Tina has always taught us, feel the chest bone, feel that sternum, make your W. That's where your electrodes begin, and then 2 fingers across. I've seen them put electrodes on top of the breast. And, you know, on a woman, how can you properly get an EKG? Are you getting the pulse that's in her breast? Raise that breast up and put it underneath where it goes. You've got some funny patients. You know, I've had some mammas tell me, hey, baby, you've seen these before. But she pulled that shirt off and grabbed them puppies and raised them up. Thanks. I appreciate it, you know. But then you've got some that are like, they trying to hold their shirt down. So I'm professional, ma'am. You know, I'm not trying to show everybody your business. I will raise your shirt up just to where I need to go. We do have a good time. And you got to joke. Sometimes you got that time where you want to go in a corner and cry. At the beginning of this, I told you that I had a classmate that was dying of cancer. Fortunate enough, I do know she's still alive. Thank God. But that day I tried to get her blood. I went to another floor, and I had become friends with a lot of the nurses. And I went to the floor and I'm going to draw some blood from another patient. And she was like, Bobby, what's wrong? I'm fine. No, Bobby, what's wrong? She actually took her syringe of medication, gave it to her coworker and said, please go take care of this for me. I need to go talk to Bobby. We have to go somewhere. We went up to the side somewhere, and she was like, gave me the biggest hug. And look, because I knew this person, because I knew that patient, it hurt. Don't be ashamed to go up somewhere and cry, wipe your face off, and get ready to go with the next patient. Does your job get to you? Yes. Can it? Yes. All the time? It can. Oh, it's just drawing blood, just doing an EKG. It's not just that. We are saving people's lives. So I'm telling you now, be prepared. Am I telling you be cold-hearted? No. Patients don't want you going in there and being completely rude. They looking for somebody that's going to be caring. You'll be surprised what kind of response you get from that patient. You'll be surprised. The rule of thumb is 2 sticks and then you call somebody else. I'm not going to lie. There's been a couple of times, not very many, less than one hand, that I put the needle in the vein, got maybe 1 tube, stuck it again, and the blood started coming, but then stopped. That was it. Didn't even fill up a tube. Oh, what about one more time? That patient giving me permission to do one more time. Did I feel confident enough to do it? Honestly, yeah. And I did. And was able to draw my rainbow. In the ER, that's all I draw mostly is rainbows. But that was because I won their trust.
Explain a rainbow. Some of them came
Rainbow. Oh yeah, forgot.
Rainbow.
A rainbow. A rainbow is going to consist of red, light blue. Well, let me do it in order. Light blue, red, light green, and purple or lavender. It's done in that order every time. Your red does not have an additive in it. Your blue does. Blues are usually used for a lot of. You ready for this, Miss T? A lot of PT, PTTINRs.
APPT.
You'll start learning all the tests here if you haven't done it already. And that was one of my stressful things in class was how in God's name am I going to remember what tests go for what tube? Let me relieve some of that stress. You will get labels that tell you PT, PTT is a blue tube. Mycoplasma is dominantly a pneumonia. It's for if you've got pneumonia, dominantly walking pneumonia. That goes in a red tube. Your CBC, everybody knows CBC is a purple. Your chemistries are all in your red tube. I mean your light green tubes. We in the hospital use an ammonia test, lactic acid, ammonia. My mind is blank because that's the 2 I use a lot in the ER. Goes in the dark green tubes. The difference between the dark green and the light green is one is a SST tube. It's got the serum separation in the bottom of it that when you spin it, it splits the cells from the serum. And that little wax, the wax that's at the bottom of that tube, it comes up. It's pretty cool. It'll spin real high and real fast, and then once it gets there, it'll split the serum from the cells, and it almost looks like dirty oil. It's almost what it looks like. The dark green, depending what test it is, because both the light green and the dark green have heparin as an additive in the tubes. The difference is um, the ammonia and the lactic acid, and there's some other tests, y'all, but off the top of my head, that's all I can think of. We have to put those on ice. You have to put those on ice. And they usually don't spin those because they have to use the whole blood. But when they do spin them, it does separate, but you have to use a tube to suck the serum out of the tube itself. It's a pretty cool process. And they just use the serum to test for whatever they're looking for. So we end up having to do a lot of CBCs, a lot of CMPs. And lately with the COVID, we do a lot of BNPs. Don't get that confused with the BMP. Difference between BMP and a CMP is your liver enzymes. One shows it and one doesn't. So I know I'm throwing a lot of these tests at you. It took me a while to learn all those, but you get used to it real quick. So don't fret of what tests. Miss Tina used to tell me that all the time. Bobby, stop it. She would throw markers at me from the front of the class. I sat all the way in the back by her desk. Don't think she don't have a good arm. But listen to what Miss Tina has. Take what she tells you and bring it to heart. I love what I do. I love my patients. I actually got a compliment the other day to the ER director. He got it, and it was from a patient. That patient specifically named the X-ray tech and myself for taking the time and taking care of them. I don't look at it as a hero thing. I look at it, it's my job. It's my job. And that's what we're there for. We're there to take care of the patients. Get ready to hit the workforce, y'all. What you're doing in classroom is different than the actual workforce. You're gonna take what she teaches you, what Miss Tina teaches you, and it will be useful. But the workforce in the hospital, whether the hospital, doctor's office, wherever, it is a different world. Anybody have questions?
Okay, what do you think is like the hardest transition between what?
I have gotten you might about money.
No, she's asking what's the hardest transition for like from classroom to workforce. Oh, what's the biggest transition difference between classroom to workforce? You heard Bobby?
The
I mean,
hardest transition between the classroom and the workforce.
yeah.
Attitudes. Attitudes. Um, in the classroom, we got really comfortable sticking each other. We knew about where everybody's veins were. Um, we just got comfortable, and I don't know if it was just because we were sticking each other so much that the needles didn't even bother us, but we got real comfortable with everybody in the classroom. We were like family. We actually still, there's several of us that still talk to each other and, hey, how you doing? What you doing? Still, uh, I'm not afraid to say it. I still call Miss Tina. Miss Tina is, we've become friends, but she's still my teacher. Tell me this, because recently on us in the lab, they've changed the process of a rainbow drawing. Correct way is light blue, red, light green, and purple. Well, now the lab's telling us they want us to draw red, blue, green, and purple. They just changed the process of the red and the blue.
Well, like I said, the red doesn't have an
I was on the
attitude.
phone with Miss Tina.
Oh,
I told Miss Tina, is this right? She said, no, Bobby, the way you thought it was is the correct way. Okay. We'll come to find out the reason why is mainly because, especially when you draw it with a butterfly. When you draw a butterfly, you use a red tube first. That's basically your waist. Then you do blue, red, green, purple. We do that because it fills the blue tube up more. The blue tube actually needs to be the fullest tube always, um, because of the additive that's in it. It has to be mixed to the fullest capacity with the blood so we can get a good reading on that blood. They use that for patients that do heparin. They get a heparin drip because it could thin their blood too much. So we need to do a PT-INR on them or a PTT, and make sure the blood's not too thin. Do we need to slow the heparin drip down? Do we need to stop the heparin drip? These tests are very important. You don't think it is, but it is. It's very important. So, like I said, working in the classroom, going into the workforce, you do get a little nervous. Classroom, we have access to all the butterflies we want, all the Vacutains, all the needles, anything we want. In the workforce, they give us about 5. If I'm lucky, I can get a box of butterflies, which is 50, and I have to split that with 4 other people. And try to make those stretch as much as possible. Sometimes I can use all the butterflies in one day, myself and my relief, because of all the geriatric patients that come in. Geriatric patient will freak you out. Sometimes their veins are as big as my thumb. Some of them, they're as tiny as a piece of thread. You never know what you're coming against. In the classroom, we all knew each other. We knew what we were facing. Everybody was healthy, and everybody's veins were great. You go into the workforce, you've got to watch out for God dog it, my mind is blank. The commissions that come in to make sure all of our licenses are fine, to make sure that the Medicaid, which we don't mess with Medicaid, we've got the corporate port office that handle all of that, the billing department, but they still come in and follow us. They make sure that we're doing procedures like we're supposed to. They want to make sure that we're doing the AIDET procedure, which is acknowledging our coworkers and patients, cross them in the hall, identifying people. It's just different steps. They want to make sure that we're doing it all. Classroom, we don't have to worry about all that. We know who each other are. Good morning if you want to tell them good morning. If you're that kind of a person to say good morning, great. Good morning goes a far way. It's just different all the way around. It's hard. We go into the lab, in class, we draw. You go into a class, which is the patient's room, it's a whole different world because you don't know this patient. You don't know what kind of veins they have. So you got to be mentally prepared. Mentally preparing yourself for a hospital because this person could be sick as a dog or they can be as healthy as an ox. You just never know. So I think really the hardest transition would be the mental part. Does that answer your question?
So thank you.
Or help?
Yeah. I got a question for you, Bobby. So compare when you first started, how procedures were to now with COVID going around. Has procedures changed drastically or just a little bit?
Drastic.
Yeah.
We went from going to a patient's room. Okay. I'll knock on the door. Knock, knock. Hi, my name is Bobby. I'm with the lab. Go up to the patient. Oh, can you please tell me your name and date of birth? Tina Housley, November, blah, 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 19, blah, blah, blah. 1991, right, Miss T?
Oh yeah, all the time.
Yeah. Hi, I'm gonna draw some blood. The doctor's ordered some blood for us to draw today. Go into the patient's room, you look at the site. As soon as you walk in the patient's room, you're looking on the door, you're looking on the walls, you're looking for signage. Patient can only be stuck in the left arm or the right arm, only can have a BP on whichever arm. You're looking on their arms for any kind of different colored bracelets. They can be allergic to something. They can't be drawn on a certain arm because they had a mastectomy. Just different reasons. They could have had a fistula. They could have had what's the other word I'm looking for, Messina?
A fistula?
Fistula, and then a graft.
Yeah, a graft.
So you got to be careful of stuff like that. That's an easy patient. COVID came. I'm now in the ER at this time. Patient comes in, all in your face. We're wearing N95s. We're wearing like a gas mask type with the filters.
Mm-hmm.
Instead of the N95s, just because they actually vented better and it was easier for us to breathe through. But here's that patient coughing and hacking in your face, and guess what? Here we go, bouffant, glasses, N95 or our masks. We got to put our gowns on, but got to put shoe coverings on. Got to put gloves back on. And you go into the room. You got to close the door, close the curtain. You got these zero pressurized rooms that's sucking all the bad out of the air. So you got these machines going and trying to hear the patient and the patient hearing you. It's a big change. We went from not having to wear PPEs to where now we have to wear PPEs all the time. Yeah, on the floor, or even before, after I got off the floor, we had some, probably saying 6 months time, I think I wore PPE twice. To now I'm wearing PPE on average. I'm changing about 15 to 20 times a day. That's a 12-hour period. We had a patient come in last night, COVID positive. Stats were really, really low. And if we couldn't have got that patient stable enough, we were fixing to have to intubate the patient. Ambulance calls you, they give you a rundown of what's going on. What we do, back to Buffon, put our PPEs back on. And now we're waiting for the ambulance to come. They usually give us an ETA of how long it takes before they got there. So we time it ourselves. We don't want to be in PPEs no more than we have to because they're just hot. They sweat. The transition, it's almost a culture shock. You know, you go from being comfortable to now something's invading your space. You have to dress more. It's a different world. This COVID is nothing to play with. We have had a few of our staff sick with the COVID in the ER. A few being, I know 5 since this started. I've been lucky so far. I have not been sick with it. I'm fighting sinuses right now. But I guess that's to be expected. It's hot, cold, and then here we are wearing our PPE. Wet, dry, wet, dry. But despite everything, I love what I do. I love being able to take care of that patient. I love the fact that I've been trained that I know what I'm doing. You know, what's fun is to do an EKG, and you hear the nurse on the side of it over you telling you, that's good. Go ahead and print the report. No, it is not good. I've got artifacts. Doctor don't want no artifacts. The nurse can tell you some of them can tell you, oh, they flatlined. Well, that's easy to tell. I think a lot of the nurses, they rely on what the machine's going to tell them. A lot of machines tell you bradycardia, tachycardia, sinus rhythm, left ventricular, left bundle block, right bundle block. Why? Take the knowledge Messina taught you. Be the badasses we are and take the knowledge that she taught us and show them that you know what you're doing. I've actually brought a doctor 3 reports one time. Why? I didn't like them. And he questioned me. Why do you have so many EKGs? I didn't like what I saw. I was trained. I know what I'm looking at. I can break this down. I can interpret this for you if you'd like. And he looked up at me and said, really? Yeah. 9 times out of 10, your nurses cannot take the knowledge that you're taught. Keep it up, practice it, use it, because that's what's going to save that patient's life. Be prepared to, at times, work hard. Then there's going to be times that you can sit back and relax. but our main priority is that patient's life. I've been through a lot. I've seen gunshots. I've seen, unfortunately, a baby. 3 days after that baby died, y'all, we actually delivered a baby in the ER. As soon as the baby was born, OB was down here in the ER, and they brought the patient upstairs. We delivered the baby and the placenta. Put it all on the mama, and off they went. Good job, everybody, and they took that patient up. Healthy baby. Is it worth it? Yes. Is it worth the transitions that we go through? You're wearing PPE in the classroom right now. Is it worth it? In the end, it will be, I promise. I promise. The smiles on our faces, walking in that room. Hey, how you doing? Oh, such and such. What you in here for now? You just saw him 3 days ago. Oh, Bobby, you know, yeah, I know, I see it. We have one that has sickle cell. Every time. I'm one of the very few that can get blood from her. Where? Right here in the wrist. Right there. In the wrist. Not in the artery. Those little tiny veins is the only place I can stick on that patient. And that's depending on how bad they are. Sometimes the doctor has to go and do an EJ line. They go into the vein on the side of the neck, on either side. Sometimes they have to do that. But that patient just cries and cries and cries because they have cancer as well. Go in that room. Oh, such and such. You're back again. You're hurting, huh, baby? Don't worry, I'm here. Don't worry, nurse such and such is here. We're going to take care of you. You know that. We got you. And just those words alone makes that patient relax, calm down, and the relief that they have to know that you're going to take care of me. The reward. COVID's nothing to play with. Get ready to dress in and out, in and out, in and out. If you're fixing to quit or fixing to graduate and get out of class and certified and get you a job, be prepared, folks. We don't never know what's going to happen next. I'm hoping this COVID is over with soon. We'll see. But we're in a pandemic. I was 6 months, and then the pandemic started. It's like a big hurricane. I was married for 10 months, and I got hit with Hurricane Katrina. You don't know. You don't know what's going to happen. Any questions?
Well, I thank you, Bobby, for sharing your experience with you. What you're doing in the hospital. Keep it up. You know, you gotta watch out for the rest of them that's there right now. You got a whole bunch of classmates over there with you.
I do. The last time I spoke, one of them looked really familiar, and I couldn't like place her. And she was like, "Oh, I remember you. I remember the last time you was here and spoke." And she moved her mask, and then I realized who she was. I remembered her face. We do have a lot of Unitech students there that are doing their clinicals and working.
So the jobs are out there.
Be prepared, y'all, and I wish y'all all the best. Do you have any that's fixing to graduate?
I have a few that's doing clinicals right now at different places. Nobody's coming out right now. Everybody's pretty much coming out the following year. So pretty much everybody you see on TV.
Any guys?
One.
Do you have any males in your class or all females?
No, No, I have one male, Mr. Darrell. You see him?
I'm the oldest. I'm the only male.
The only one.
The hot dog. I don't hold
You hold that
that
sucker.
that
Not no
thing no
more.
more, huh?
Not no more.
I can be the baby.
Yeah, you're the baby.
Yeah, I actually, we have some people, we have patients that'll tell you you're fat. I had one that told me the other day, I relieved Hilda, who is a coworker of mine, and the patient said, I've only seen two people in here so far, and the only ones that come and service me, they're all fat. Needless to say, I wanted to put my fist in his mouth or find an 18 gauge needle. You can't do that. Not legally. But they don't need to know what size needle you have. And all I could do is draw the blood and say thank you and walk out and cuss him out later. But then you've got some that are super sweet, super, super sweet. So, but I wish y'all the best. Thank y'all for having me. Do pay attention to what Miss Tina tells you. From what she told me the other day, we did a test run on this Zoom thing. The notes y'all are getting is nothing compared to what we had. Nothing. Give me a minute. I'm gonna show y'all what kind of notes y'all missing out on.
Where's the pepper? Why do we have less notes? Why do we have less notes? It's hard to put them on that model. Because a lot of it's like practice stuff. That's why I started doing the option of paper tests and previews and
Y'all see this?
that's it. That's his binder. He still up.
This is only one book.
That's EKG.
I actually have. I actually have four 4-inch 3-ring binders to cover all my classes, all the notes that she gave us. So y'all are missing out on a lot of notes because of COVID.
But it just makes it a little harder.
They won't have no 4 3-inch binders full.
Close. Because I changed it up a little bit for EKG. And they already starting. You don't see it? The heart is in the back. On the board.
What's the next subject? EKG?
Yep, we started on the heart today. So they started breaking down the heart, saying what each one does and everything else. So I'm about to finish that up and get it on. So they don't have a binder, at least a binder full.
I wish y'all the best. I wish y'all the best. What you cooking over there, girl?
She's on mute. She can't talk.
You got your phone on mute.
I put her on mute.
She fixing to cook something. I want your address. I'm coming. But anyway, folks, I appreciate y'all having me today. Feel free to contact Miss Tina, who can get a hold of me if y'all have any questions. And I'll be more than happy to answer them for you. But if y'all don't have any more questions, I wish y'all the best.
No, that's it. Thank you very much.
My
Okay.
pleasure, and everybody have a Merry Christmas. I know it's early, but everybody have a Merry Christmas and good luck with everything.
Thank you. You too. Stay safe.
Will do. Y'all too.
Bye.
Bye.